very much, Simon. It was a very interesting case. We had, by the way, still a question from the audience about surgery. At what point would you consider surgery for your patient if he is in a better nutritional condition, or is it the situation you would like to continue? And what would you do with the follow-up with the PET-CT? Can you hear me, Simon?
Sorry, I couldn't hear you just now. Sorry, can I say that again?
Oh no, there was a question. How would you do the follow-up in your patient? Would it be with PET-CT on a regular basis to see if there is any recurrence, or what is your ideas about that?
Oh, I would do regular PET-CTs, yes. Well, we can't do endoscopy anymore, of course. So imaging is the only way.
Okay. Okay, so I'm very happy to introduce Professor Jacques Bergman. He is one of the leading gastroenterologists worldwide in the treatment of early esophageal cancer. He has established a very good local Dutch community on expert centers treating early Barrett's lesions, and also published some landmark papers in this field. So Jack, I'm very happy to have you here from Amsterdam UMC, and he will introduce the next case.
Thank you, Richard. Hopefully I can get control. There we go. So this is a male patient, 66 years old, esophagitis in the past, aortic valve stenosis and hypercholesteremia, and he presents with a 8 centimeter long Barrett's segment with this ugly looking cancer. And the question now is, how would you resect this? Would you do this endoscopically with a cap-based technique or with a multi-band technique? Do you think this patient needs an endoscopic submucosal dissection, or stop all the endoscopy, go straight for surgery here? So the poll is on your screen, so please pick a number. I will do one same and then submit. Simon.
Yes.
In the Far East, this is hardly an option to choose from this, but I will throw it at you. What are you going to do with a case like this?
Oh, definitely ESD, I think. So it looks a rather big one, and in our hands, we would definitely do a ESD. The multi-band technique is, well, we do it, but obviously it's not as clean and not as thorough as a ESD.
But would you be able to resect this with a multi-band technique or the cap technique from a technical perspective?
Not. I think probably not. It's not flat. It's pretty polypoid-like. So ESD, I think, would be the choice.
Okay, maybe we can see the results of the poll. So there's a clear preference for ESD if it comes to the type of endoscopic resection. And there's also about a third that would take this patient straight to surgery. The main reason for us to do this with an ESD is that the lesion is simply too bulky. So if you would use a cap-based technique, anything you would suck in the cap and then would resect would still not be at the base of the lesion. So you would only be chopping at the head of the tumor and really would not be able to get a good radical resection. So the first two options, please don't do that. That will not help your patients. The other two depends a little bit on what you think the underlying lesion is. So here's an example of how we do an ESD. I think I need to click this to have this run. It's a slightly different lesion, but it has the same bulky appearance. And again, if a cap-based technique here would not get the whole lesion out, this is after marking the lesion with coagulation markers and then doing the submucosal injection. Now there's a whole variety of different ESD knives and tools for this available. Here we are using a new knife of Medtronic that has two different features, a a really knife-like tool that allows you to make a cut. You can see here a knife, and then you can change this by switching it to a isolated tip knife that in this case allows you to safely insert into the submucosal space and then use a bolt tip approach to do the circumferential incision, and you can switch back and forth between the I knife and the O knife to then complete this dissection. Final cut. The video plays a little bit slower than it would run in real time. This is then how it looks after the ESD. So if we do an ESD, Ken, what kind of workup would you do before doing an ESD of a lesion like this? Do you go straight ahead for the endoscopy, or do you do EOS or CT scan in these patients before you embark on the endoscopic procedure? And we will put the poll on screen so that you can choose either do it in all, only do it for those you suspect submucosal ingrowth, or do it only for those where you think the ESD is going to be very extensive and very risky. Ken, do you have a preference for one of these three?
You're muted, Ken. Ken, do you have an option?
Yeah, so I would like to do the EUS and CT for the patient which suspected the submucosal invasion, because the regions, the submucosal invasion, that have a potential to the lymph node metastasis, and that depends on the pathological diagnosis of the specimen. For example, the tumor region which invaded the lymph vessel invasion or a deeper invasion to the submucosal is have a potential to the more than 30% of the lymph node metastasis. So we should follow up by CT scan and the ES.
Maybe we can see the results of the poll so that we save a little bit of time and can move forward. So the majority will do EOS CT only for those cases where they suspect submucosal invasion. Still, there's 1/3 that will do EOS and CT in all early Barrett's cancers, even the ones that clearly look mucosal. I would argue against that. That really doesn't change anything for most of the early mucosal lesions. And in fact, we would only do CT and EOS if we really feel that the ESD is going to be risky and very extensive. But for a straightforward ESD, like the one we showed you on the video, we would actually would not do any additional staging apart from the ESD, and then have the ESD specimen guide for the management. But again, this is open for debate. And I think if you're going to embark on ESDs and you're not in Hong Kong or Japan, and this is something that you're not very experienced in, you better think twice. And then doing an EOS and a CT scan is probably a wise idea before you're going to tackle big chunky lesions like this.
There is a comment from Daniela, Jacques, about the PET scan because of disseminated disease. This is a better tool to find out if there's any metastasis.
Yeah, I can make the comment. I think I agree with you that most of the early stage mucosal disease don't need investigation, but for T1b, why not? You could have already lymph nodal invasion and or lymph nodal involvement, And to do a PET scan after a resection, it would be meaningless because, you know, you could be reactive nodes from the ESD. So definitely the pathology will guide treatment, but if you know already that there is a lymph node that is positive on PET, then you might change treatment and maybe even forego the ESD.
I accept that. I think it all has to do with the pretest likelihood of a patient harboring positive lymph nodes, and we will get to that in a second. So back to our
question that popped up from the audience, Jack, is about the accuracy of EUS after ESD.
It's useless to do it for local staging. The only reason why you should do EUS after an ESD, you better wait until the ESD wound has completely healed, is to look for lymph nodes, and if they are there, they should be sampled. Because then the reactive changes due to the ESD may cause lymph node enlargement. But the real value of EUS in this setting is not for local tumor staging, so not for T stage, because a bulky lesion, if you compress that with your endoscope, it really will give all kinds of artifacts. It's really only for the lymph node staging. And then EUS is the most reliable tool because you can combine it with fine needle aspiration.
Right.
So this is his pathology. He comes back with a SM2 cancer, partially poorly differentiated, no lymphatic invasion, and all resection margins are free. So now what's next? This is an ugly submucosal cancer. Have him undergo surgery, even although the cancer is completely out. Well, maybe esophagectomy is not enough. He also needs radiotherapy, a neoadjuvant for that. Or, well, yes, he has an ugly cancer, yeah, but he might still be treated and followed up endoscopically. So while the poll is up, Daniela, you're shaking your head. Is that because you cannot choose, or?
Oh no, I chose. I think this, you know, with 800 microns of invasion and poor differentiation, I'm not sure I feel comfortable in doing endoscopic follow-up on this patient, especially if he's young and fit for surgery.
Okay, Trevor, how would the Australians manage this?
Well, I think our surgeons would probably go for surgery as well, but I wouldn't give chemoradiation before or after. It'd be straight to surgery.
And Christiane?
Well, I completely agree with Daniela and also with Trevor. No radio chemotherapy, but we would, with the 800 microns, definitely go for esophageectomy at the moment. We don't know what will be in the next 10 years, but at the moment, we would do esophageectomy.
Okay, Leah, can you show the poll results that we have on this? Okay, so the majority goes straight for esophagectomy. And then there's about a 50-50 split between combining that with chemo or moving the other way and still staying with endoscopic management.
Actually, Jacques, maybe can I ask Ken, because, well, we don't have that much experience with Barrett's cancer in Asia, of course, but there's quite a lot of data from Japan on SCC, especially for T1b lesions. Ken, would you like to make any comments? What would you do in a lesion like this if it's a squamous cell in Japan?
Okay, thank you, Simon. So as you mentioned, so we have not so much experience about the Barrett esophagus, but we have much experience for the ESCC for the after the ESD endoscopic dissection. For the squamous cell carcinoma patient, the patient who invaded the submucosal after ESD, recently there are two candidates for the esophagectomy or chemoradiotherapy. But recently, from the result of the JCOG 0508, the chemoradiotherapy after the ESD, it shows a good survival benefit. That is a single arm phase 2 study. So we had not which is better than the surgery or chemoradiotherapy. But recently we usually use the prophylactic chemoradiotherapy after the for the patient who shows a submucosal invasion after ESD.
You can. I think it's important to point out that squamous cell cancer and Barrett's cancer, especially for these T1b, may be two totally different diseases, and the lymph node metastasis rate for squamous cell neoplasia probably is worse than for Barrett's. And also the data that we have and the reliability of data that we have for squamous cell cancer when it comes to the relationship between tumor infiltration and lymph node metastasis is way stronger because of the good quality surgical and endoscopic series that we have on the Far East. For Barrett's, there's a lot of, the knowledge gap is significant here. So here's what the current guidelines say for early Barrett's neoplasia. So if it's a low risk, very superficial invading submucosal cancer, you can stick with endoscopic management. But for a case like this with invasion, which is deeper and additional other high risk features, in this case, he also had a poorly differentiation, the guidelines say that you should do a esophagectomy with lymph node dissection. It all has to do with how we estimate the risk of lymph node metastasis in this patient. And for submucosal cancer, especially the deeper ones, this rate varies quite significantly between series. So back to our patients, how high is this risk? What's percentage-wise? How do you think this type of cancer, what do you think is lymph node metastasis, local lymph node metastasis risk is? I'm going to poll everybody of you. Just give me a percentage and no argumentation for this. So Richard, how many percent?
30%.
Ken?
Yeah, 40%.
40%. Simon, higher or lower? You're muted. We'll move to Daniela while Simon unmutes his microphone, so we're getting back to him.
Sorry, I meant to say it is roughly the same 30%. For
30%?
SCC, it would be much higher.
Yeah,
Daniela?
I agree. Two risk factors, depth and poor differentiation is about 30 to 40%.
Okay. Trevor?
I would say between 20 and 30%.
Okay, we're getting there. Christiane?
Well, then I would say 25 to 30%.
Okay, okay.
But it's something around this.
The point is that our estimates here are largely based on surgical series. And most of them, especially for Barrett's, are retrospective and at best a mixture between squamous and Barrett's. And usually they report resections, surgical resections from a time in which the distinction between SM1 or SM2 or SM3 really had no clinical relevance. The surgeon only wanted to know if there was a radical resection and if there was cancer there. And they tend to overestimate the lymph node metastasis risk because these surgical specimens, they were routinely cut at best in 5, sometimes even 10 millimeter intervals. So that means if you make slices like this and you then find a positive lymph node, then you would relate this positive lymph node to where you found the deepest invasion, which is in fact not where the deepest invasion actually is. So if we take ESD specimens, now we cut the specimens really in very small slices and we make additional cuts until we really find the deepest invasion. So we're looking at a different accuracy of tumor staging now in the era of ESD than our reference, the previous surgical series. So our estimate is that for the low-risk submucosal cancers, this risk is neglectable. But for these high-risk T1b cancers, based on like a meta-analysis that we've done on this, that the risk is somewhere between 15 and 25%. Let's say 25%. That means that this patient still has a 75% chance of already being cured. And that 75% of these patients will then undergo needless surgery. So an alternative, especially if a patient would be high risk for surgical intervention, would be just to wait and see and do endoscopic follow-up and EUS follow-up and wait for that small subgroup at best 25% to manifest with a positive lymph node, and then to treat those with chemoradiotherapy and surgery instead of esophagectomy alone. And then simply accept the potential loss for few in favor of preventing surgery in most. And this is a multi-center prospective study that we have in the Netherlands and with 8 other international centers. Some disclaimers for this route. It may appear logical, but it is investigational. You should only do this if your surgeons and oncologists and radiotherapists are on board for this. And if this is done after good consultation with the patient, I usually send my patients also for consultation with the surgeons. And bear in mind, this is not all T1b cancers. They need to be resectable endoscopically, and then to have an R0 resection, and then to have a full negative restaging after the ISDE is healed. And then there's really very strict follow-up every 3 months, also with a PET-CT annually. Any comments for this? Are we crazy by doing this, or is there some validity to this? Christiane, can I pitch this at you first?
Well, I really wanted to ask you, how do you yourself trust your own endosonography and your own endoscopy if you pursue this strict follow-up? Because you are a specialist on this, but we do have also a surgical endoscopist, and we are very much trained. But how do you really trust on your strict follow-up if you go with this rationale? How do you trust your own endoscopist and endosonographist to be sure that you don't miss anything, and probably also to be sure not to miss the biology of the disease, that you probably all of a sudden have a lymph node which is not local to the disease but anywhere else?
We don't know. The only thing I can tell you is that our experience over the last 10 years, in which we have started to treat many of these patients, generally because they were too old or too frail, that these simply did not manifest these distant or late metastases. And that all the patients that we sent to surgery, only a very smaller group than we would have anticipated actually had residual tumor or positive lymph nodes. But there's very strict selection criteria for these centers if it comes to the quality of the endoscopic follow-up and the EOS follow-up. So this is really something that should be reserved for high volume centers and very dedicated endoscopic follow-up. There you're absolutely right.
Jack?
Yes, please.
Let me ask you, if you did have T1b high grade and more than 500 microns, would you go for this study?
Yes.
I wouldn't.
So what convinced me was that I had 7 years ago, we were already doing this for relatively old and frail patients. And then within 2 weeks' time, I had 2 40-year-olds, both having young kids with submucosal cancers. And the first one really had poorly differentiated lymphatic invasion. He had the whole enchilada for straight going to surgery. If he would have worked in any surgery department in the world, they would have sent him to surgery, and he simply refused. And so I had him talk with surgeons and with several of my colleagues. I actually wanted to speak to his wife to make sure that everybody was aware of what kind of responsibility he was taking. And he's now 7 years out, and he's one of the patient advocates for this, for our study. That's an anecdotal example, but I can show you 30 cases that we've done retrospectively, and there's 60 patients already in this prospective study, and it's overseen by a DSMB, and there's for no means any reason to consider closing the study. So our baseline hypothesis is really still very strong halfway through the study. So I think we will be changing the field here.
Well, you are
Jack,
still...
how many patients do you need for this study? What was your hypothesis?
155, 5 years follow-up.
Based on 30% metastasis, or 25, or?
There's well, it would be too complex to explain the sample size calculations and the reasoning for this, but there's very close supervision by a data safety monitoring board that logically, if we would have patients presenting with a larger number of patients presenting with local lymph node metastasis within the first year, or if we would have any patient with distant metastasis, then we would reflect on if our hypothesis is still valid. But the 1 or 2 recurrences that we've had, they were all within 6 months after the baseline, and they were cured still with surgical management or with very focal chemoradiotherapy on that single local lymph node.
But Jacques, I mean, if I know we try to preserve the esophagus as much as possible, but some patients have this worry about doing all these scopes every 3 months and PET CT scans. Would you offer chemoradiation as an alternative?
Yeah, well, first of all, we discuss with the patient and tell them that the standard guideline advises them to undergo surgery. There is a possibility to do definitive chemoradiotherapy, but if we do that in all our patients, we will never know, because we will never know if we just chemoradiotherapy a healthy esophagus with no local lymph node metastasis, or that we have effectively removed any small residual tumor cells. So that's if you do a single arm definitive chemoradiotherapy and you compare it to a historical outcome with surgery, you may be changing one overaggressive treatment by another overaggressive treatment, which is less overaggressive than the primary esophagectomy. Then we still don't know. So the only reason to get out of the woods is to do a good quality prospective study without an intervention.
Maybe one final comment by Daniela. She put it up about the reduced survival after lymph node metastasis.
So we did a study, a multi-center study in the United States. It was a very small group of patients where they had a T1b tumor reviewed by 3 expert GI pathologists to confirm it was a T1b, because that's also a little bit difficult, to evaluate. And then these patients underwent esophagectomy. And exactly as you said, when there were 2 risks associated with the tumor, the patients had about 25% a risk of nodal disease. When there were 3 risk factors, you went up to 35% risk of nodal disease. And what was interesting in that study was that patients that had no nodal disease had 100% survival at 5 years. Patients that had 1 to 3 positive nodes had about 66% survival. So you take a big chance here, you take a big risk. And in our hands, surgery has a mortality about 1.2%. And I don't know if I would feel honestly offering a healthy individual to miss the opportunity to be cured by trying to spare the esophagus. So,
but Daniela, one important thing here is that despite that those patients underwent radical esophagectomy with lymph node dissection, the ones that had positive lymph nodes, still 1/3 of them died of a recurrence. So it's even if you do this, and if you do find the lymph nodes.
But that's the key. That's the key. You had to operate them before they develop nodal disease. You might have had a better outcome on this patient. Once they have 1 node positive, their survival risk is much higher. This disease, you're assuming also that the tumor goes from esophagus to nodes, but in the meantime, there is also potential of systemic dissemination. So you don't really know what happened if there is, positive ctDNA. Maybe that will help us in the future to really identify patients that still have harboring tumor within their body. But I don't particularly agree that taking them when they have developed 1 lymph node is equivalent to do surgery when they did not have any nodal involvement. I think that changed the game.
Okay. Daniela, thank you, and also Jack, thank you very much for this very interesting case. I think we can continue discussion, but we have to continue also the tumor board because we have 2 patients to discuss still. So thank you, Jacques, and we're eager to hear your results of your preferred study, hopefully within 2 years or so.